This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
In a way. So we'll be going through bits about sterilisation, device failure, and device explant as well, and evaluation. So what do I mean when I say something is sterile, or what does sterilisation mean? Are you wanting a surface or something that is sterile? It's going to have the absence of all living organisms, microorganisms such as bacteria, yeast, molds and viruses. So if something is sterile, or I guess can you guarantee something is 100% sterile, or all your batches are 100% sterile? No. So within the medical device industry, we have a sterility assurance level. So because we can't say that everything will come out sterile 100% of the time, there's kind of a baseline that we want, or that medical device companies sterilise their devices to, is that the probability of no more than 1 in 1 million of whatever is going through being sterilised is actually non-sterile. So that's pretty low in terms of 1 in a million, but still 1 in a million. If you have 1 in a million devices that is not sterile and that non-sterile device goes into a patient, that could be pretty catastrophic. But how do we test if something is sterile? So typically when things have gone through the process of being sterilised, you might take a batch and you test that batch. So that batch, whether it's a device, it's in a packaging, is then put into an inoculation media. If that then grows bacteria or becomes infected in some way, then it's no longer sterile. If it stays non-infected, then the sterility check has been passed. So there's a fair few different ways that you can sterilise medical devices. I've put 3 main ones, and really 2 of them are the ones that have the main part of the market. So the first one is irradiation. So the most common type of irradiation is the gamma irradiation that's used for sterilisation. That's the most common. So the doses, and I'm pretty sure I took these doses for gamma irradiation. I would have to double check for the other ones. You need to give a dose of radiation around 8 to 35 I think it's Geigens. So if you're looking, that's the sort of range that you need to sterilise, or is used for sterilisation. An acute lethal dose is 0.01 kilogeigens. So the amount of radiation that you're using, or in the chamber where devices are sterilised, it's a lethal dose. So if you're thinking about that, think of the setup that there needs to be able to have gamma radiation facilities, so that it's insulated enough that the radiation that is being used to sterilise the devices, if that's the range that you're needing, compared to the dose that is an acute lethal dose, what sort of, I guess, when you've had an X-ray, the person that's taking the X-ray will usually wear some sort of vest that's protecting them from the X-rays. You need this on a big scale. I've put the standard for it. I had a read through it. If you'd read through the ISO 993 standards and thought they were a little bit dry, then I wouldn't recommend reading this. But it's essentially telling you what sort of doses you need to have and what sort of procedure you have to go through to sterilise a medical device using radiation, and being able to validate that process as well. So that's one of the methods that's used for sterilisation. A bit more information about the gamma radiation. So the source of the gamma radiation comes from 60 cobalt. So cobalt usually has a element, its number is 59, so it's a radioactive element. So it's the continuous decay of this isotope that produces the gamma rays. So even though you may be, well, things are getting sterilised via gamma radiation, a lot of these plants, depending on how big they are, it may be continuous. You always have devices of stuff going through the plant being sterilised. But with the gamma radiation, the actual source, the isotope, it's continually emitting gamma radiation. So that's one of the downsides with this. And then you also have very high capital costs involved in setting it up, because the plant or the site where you have it, you're going to have an isotope that's spitting out quite high gamma rays, higher than lethal dose. You want to be able to isolate it in the room, so setting up a facility to do that is quite high. So from a materials perspective, what materials are okay to get gamma radiated and what ones are affected? So your metals, your ceramics, pretty much okay, they don't get affected by it. Your polymers, depending on which one it is, it may or may not get affected by gamma radiation. So I've put a table there of some of them. You may be familiar with some of the names through some of the other lectures. If you're not for some of them, then that's okay. I'm more showing that not all of them are okay. So a gamma radiation, if you've got, maybe haven't gone through polymers and polymerization, it creates, most times with creating a polymer, you need a free radical. So gamma radiation can create free radicals. So sometimes that's how it can change polymers. Sometimes you'll see polymers, they've just turned yellow with gamma radiation. So sometimes yellow can be okay, but sometimes yellow is an indicator of oxidation has occurred. So if your polymer has gone through gamma radiation without doing any sort of chemical assessment and it's gone yellow, I would question whether or not oxidation has occurred. If oxidation has occurred, has then changed the chemical properties. If it's changed the chemical properties, is that then going to affect how your material behaves? Probably yes. So gamma radiation is one type of sterilisation. Another type is ethylene oxide. So ethylene oxide is a form of gas. It is very toxic and it is very explosive, so it's very flammable. I've put in another terminal sterilisation procedure. I don't know if I put in the other two in the radiation. It was a terminal sterilisation procedure. What does terminal sterilisation procedure mean? So a lot of medical devices, from syringes, catheters, will come wrapped in plastic, or it will be housed in something. I'll go back to this. So you'll get it, here's your syringes in there, or you might get, without having a look, sometimes you'll get like a catheter kit and it'll be a great big kit and then it'll be housed in plastic. So terminal sterilisation means that you have your medical device, however you want it to be packaged, that whole package goes into the sterilisation setup. So you don't take the product by itself, then sterilised and then packaged it. It's packaged and then sterilised. So it's quite often, because the sterilisation is usually the end procedure, you don't really want to be touching anything once it's sterile before it goes to theatre or wherever it's being used. So a terminal sterilisation procedure means that the device, the material in its packaging can go in and get sterilised that way. So with gamma radiation, it works that way as well. Ethylene oxide does. So that means that the ethylene oxide gas, you also then, if it's going to be an end terminal or a terminal procedure, the packaging needs to be able to be permeable to the ethylene oxide gas. And usually the plastics, you'd want to make sure that that is something that it can withstand. So the materials, devices, whatever is being sterilised will go into a chamber. Ethylene oxide gas will get turned on. The amount of ethylene oxide gas will depend, when needed, will depend on what it is, what's being sterilised. But one thing that happens with ethylene oxide gas is you're left with a residue. So quite often you will need to leave your devices or whatever has been sterilised for a certain amount of time for that residue to dissipate. So when I used to test polymer discs, I used to get them sterilised by ethylene oxide. Gamma would have deteriorated the polymer, and as you'll see with steam, it also would have melted the polymer. Ethylene oxide gas, once it had been sterilised, I needed to leave it there for 7 days before I was able to use it to make sure that all the ethylene oxide gas had, or the residue had dissipated and it was no longer harmful. How long you need to leave it depends on what sort of dose it was, but I would think that most places, wherever it gets ethylene oxide treated, they usually take it somewhere for that gas to be dissipated before they actually release it. So the advantages of using ethylene oxide gas is that a lot of different types of materials are okay with it. So I was using polymers. Polymers were fine, and that is, I'll show you some examples that still may change it, but a lot of polymers are okay with ethylene oxide gas. Metals, ceramics, also okay. So the disadvantages are the residuals, so making sure that all the residuals are gone from the device or whatever has been sterilised, because you don't want that to be, because it's quite toxic. And similar to with the gamma radiation, you need quite high capital costs to set it up. So something that is going to be very flammable, you want to make sure that it's in a facility so that you can't ignite it. At least in Sydney, the main hospital there, or near the one where I worked, was the Prince of Wales Hospital. They had a great big ethylene oxide facility. When I left the university, they were in the phases of closing it down, and I have a feeling it was because of its how flammable it is. So it's quite dangerous. I've also put these are indicators. So while I said you can do batch testing to see if your ethylene oxide or your sterilisation procedure has occurred properly, you can put these indicators in with your whatever has been sterilised to make sure that it has been exposed to the conditions. So if it's gamma radiation, it will be exposed to the amount of gamma radiation that you need. Same with ethylene oxide and same with steam. So here is an example. Before it's gone through ethylene oxide, you have a nice red dot. After, it changes blue. I've used tapes that have changed colour, but it's just an indicator, or it's another thing. It's kind of like a second quality control in a way that what you're putting in has been exposed to what you're wanting, or what sterilises your device or your material. So another method is steam. Anyone heard of an autoclave? So an autoclave uses steam and pressure as a method for sterilising things. So it's the exposure of material or device to direct steam at a required temperature and pressure for a particular amount of time. So you need to have the 4 parameters for sterilisation by steam to occur: steam, pressure, temperature, time. So it kills the organisms by destroying their metabolic rate and structural components, so they can no longer survive. So the advantages of this are it's very efficient as long as you've got the right parameters there. It's speedy. you can usually get a cycle done within a few hours, and there's no toxic residues. So quite often, steam sterilisation will be used for medical equipment, so your surgery equipment, that's often metal. Steam sterilisation is usually the best option. It's quick, there's no toxic residues. Whereas with ethylene oxide, you're going to need to wait a few days for the residues to go, and depending on what settings you do for the steam, you can get it done quite quickly. So the disadvantages are the temperature and pressure. So anything that changes form over 100 or around 121 degrees, it will not survive. The majority, not all polymers, but a lot of polymers will pretty much melt at 100, even before it gets to 121 degrees, which is why autoclaves or steam is pretty much ruled out for the majority of polymers. Not all, but most of them. So I've just put some examples of different, I found an example of an autoclave, and usually with the autoclave it'll tell you what type of settings you need to do for what type of things. So there was two types of autoclaves, a gravity displacement and a dynamic air. It's not too much about that, but then you can see what the items are. You've got wrapped instruments. A lot of the time with surgeries, you might have the surgical drapes as well. So the drapes that go over the patient, the gowns that surgeons wear, you can steam autoclave as well, so they're all wrapped up. So things like that, when you've got multiple layers, the steam has to penetrate through everything to make sure it's all sterile. So when you've got wrapped instruments, textile packs, so whether or not you've got exposed at 121 degrees or 132, and then your drying time. Because it's steam, there's going to be some moisture. So then you have to leave it for a little bit of time for that moisture to go, or otherwise you'll come out with everything wet. But particularly with these ones here, we used to call it a flash cycle. I'm not actually sure if it is, but particularly for instruments or metals, you can get them sterilised within 4 minutes. Wait a little bit of time for the steam to evaporate and to dry, and then they're ready to go. So when I was having a look at all through information about different sterilisation methods that are used, I just found this table and I thought it was quite interesting. So if you have a look at this circle here, it tells you about the sterilisation market. This is specific really to the US, because the US has the biggest market of medical devices, so a lot of the information does come out there. So while I said ethylene oxide can be toxic, has high capital costs to set it up, it actually takes up 50% of the sterilisation market. Your gamma radiation is around 40%, and then your E-beam and other make up 5%. So for medical devices, 90% of the sterilisation techniques are made up by ethylene oxide and gamma radiation. I also thought it was quite interesting to have a look at how much the sterilisation process or industry is worth. So they've got here the global market in 2021, just of the sterilisation part is worth close to $7 billion in 2021. It's not as much as this value here, which is around 140 billion for the medical device, but it is still a fair chunk. So sterilising it is important. So again, just to reiterate, in terms of your biomaterials, it's important to know what the sterilisation technique will do to your material. So if it's a metal, it can probably undergo any of them. If it's a ceramic, yes. If it's a polymer, that's where it gets a little bit more interesting, and it's not as straightforward. So as always, there's different techniques, or what people are coming up with new techniques. So I've listed a few. At the moment, all of these are pretty much in the research phase. They might be in small little industries, but they're not big scale. We don't have standards for them. So while they're not used for medical devices now, that's not to say that they won't be used in the future. If we're wanting to get rid of stuff that requires radioisotopes, requires high capital costs and quite big facilities to make sure everything stays safe, in the future some of these technologies could become more mainstream than what they are now. So I found 2 papers about how different sterilisation techniques changes different properties. So this is a paper where they used 3 different types of polyurethane, and they were spun into different mats. So these numbers here, you don't need to know what they are, you just need to know that the different numbers correspond to different types of polyurethanes. Some were ozone sterilised and some were ethylene oxide sterilised. So 2 types of techniques used for sterilisation, and then they looked at a whole range of different properties, whether or not they changed. So these images here are some nice SEMs, so scanning electron micrographs. So that's, I've shown you a few of these pictures before, takes a nice image, macroscopic, of what is going on with the polymer fibres. To me, I can see slight differences between the ozone and the ethylene oxide, between the 2 of them, but without quantifying it, I wouldn't know for sure. So what they did was have a look at, so these were electrospun fibres, they had a look at fibre diameter and whether or not that changed with the different techniques. So if the fibre diameter changes, to me that says something is kind of melting or it's changing the chemical properties. So that could be one thing. One thing that they did find was the surface roughness changed. So you can use a technique called atomic force microscopy to look at surface roughness on a nanoscale. So this graph here is quantifying the surface roughness. So where you see purple, they call it the virgin material, so the materials that haven't been sterilised. The magenta or purple are UV sterilised, and then the yellow is your ethylene oxide sterilised. And then for each group of 3 is a different material. So you're comparing no sterilisation to UV to ethylene oxide. So depending on the type of material, you could clearly, or they can clearly show that the surface roughness of the materials are being changed based on what type of technique was used. So for these materials here, depending on what type of polyurethane that was, UV radiation decreased the surface roughness, so it made it a lot smoother. This one, I would say probably didn't change that much, only because the error bars in this one are very high. And then here with this one, the UV significantly increased the surface roughness. So I've said before in some of the other lectures, surface roughness is one way you can change how cells interact. So I just, rather than showing you also a whole lot of the data, because a lot of it is just graphs, they're not nice pictures, and graphs can, once you've looked at one, you've looked through them all. But the bit in the square is the summary of what they found. So they were able to show that the different types of techniques used for sterilisation did change the topography of the materials. So it changed the fibre diameter, but then what was the biological effect was that the variations had significant effects on the cells coming into direct contact with the scaffolds. So whether or not more cells adhered onto them, less cells adhere. So by changing a parameter of sterilising material, the downstream effect that you can have on the biology is something that you need to take into consideration. So this is one where they are sterilising Collagen. So the three different techniques that I told you whether or not they were good or problematic for polymers, and I usually refer to synthetic polymers, metals or ceramics. A lot of the materials these days are more biological. So collagen, you can't do gamma radiation, you can't do steam. Both of those will change the chemical structure. Ethylene oxide might, but this one was then comparing the sterilization of gamma irradiation. So while I said you shouldn't use it, it'll change the properties, gamma radiation is probably the best one, even though it will change the properties for collagen. They were looking at whether supercritical hydrogen peroxide could be a method. So I'm pretty sure in one of the new technologies I mentioned, hydrogen peroxide, supercritical fluids, do people know what that is? It goes straight from a liquid, it passes through, oh, now you're taking me back to my chem-eng. It goes, you're getting temperature, pressure, and there's another variable, so it goes through the vapor phase very quickly. Actually, maybe let me go and look that up and I'll get back to you because I'm going to tell you what it's wrong. But you can, with the supercritical fluids, it's one way to get it to go through materials a lot quicker as well. So they're looking at whether or not hydrogen peroxide by supercritical fluids is an alternative method for sterilizing collagen. So I have again some SEM looking at morphology. Are there any differences between, they had collagen films and collagen sponges, then they were untreated, gamma radiated, and hydrogen peroxide. To me they look quite similar. They then also looked at the solubility. So when you put the collagen, lyophilized collagen into different solutions, whether or not it was able to be soluble or not. They found differences. And here's just a table that's summarising all the different types of characterizations they did and how it changed, whether or not it was a film and gamma radiated, a film and hydrogen peroxide, or with the sponges. Some things changed, some things different, some things changed and some things different didn't. But you can see that pretty much, particularly for polymers, whatever technique that you use is probably going to have an effect on it. It's just what that effect is and how much that effect has on the performance of what you've designed that material or that device to do. So now we'll spend a little bit of time going through why devices fail and then what happens to them when they fail. So devices that have failed can be categorised into 7 well-defined categories. So your thrombosis, we've gone through. So if device fails because of that, so it could be thrombosis, it could be occlusion, or an embolism. Infection, so if bacteria has come in, that causes the device to fail. Inappropriate healing, so you could have too little, so it doesn't heal properly. You could have too much, and then that's where you get your fibrous capsule. You could have structural failure, So that could be because of wear, a fracture or fatigue, calcification could have occurred, adverse local tissue interactions, inflammation, toxicity, migration. The device can move, so the whole device, depending on how big that device is, could be a small one, but the whole one could move, or you could have parts of it. The parts of it can break off. And then systemic, that could be something like an allergy. So looking at all the things that I wrote down, there are a lot of things that we have covered about the host response to materials within a biological environment. So these are different ways in how a device can fail. So the next slide is going a little bit past. I guess this is biomaterials. There are other classes that you do that are more about device design. You do regulations where you find out more about them as well. But the whole, I guess, medical device, it's all development. It's a continual process. So you design your materials, you design your device, you go through in vitro testing and prototypes, you go through animal testing, and you go through clinical trials. So that happens on one side of the situation. You then have the individual implant, the materials that are chosen, fabrication and assembly, sterilization, packaging, shipping, storage, implantation, and then storage of the device as well, and then patient factors. So while the biomaterials is one aspect, whether or not a device fails, there are a lot of questions that can be asked and a lot of different reasons why they could fail. Has the device that's been chosen for the patient the correct one, the correct material? I guess when you guys went through orthopedics, there's more than one shape for a hip implant. There's more than one type of material that you can use. So depending on what type of, as an example, hip replacement the patient needs, have you got the correct shape? Do you have the correct material for that person? That could depend whether or not it fails. Has it been implanted correctly? So sometimes it even comes down to the surgeon whether or not it fails. If it hasn't been implanted, how in the correct alignment, so the correct stresses are put on it, could that cause the device to fail? Has the implant or device to be implanted, has it been damaged during the fabrication process? Is there enough quality control set up so that if something happens to it, it gets picked up before it gets implanted? Has something happened, has a defect happen when the surgeons have actually implanted it? Sometimes that can cause devices to fail. And as people who may be developing medical devices, do we know that we have carried out the correct preclinical tests to be able to pick up any defects that can happen? I guess for those of you that came to Bob's or Dr. So's lecture last week, sometimes there aren't enough preclinical tests before you put it into a patient to come up with something that you knew was going to be a failure. They did so many tests on some of their devices, preclinical and in animals, and still when it was implanted, it failed. Sometimes that is just how it goes. We do as many tests as we can beforehand, but not always, but you can't always pick up everything. So here's just another list. I guess it's more to reiterate a lot of the material properties, and what I've gone through a lot of them as well about what can happen to a material in the body and how it can be affected. So whether it's mechanical, physiochemical, chemical, biochemical, or electrochemical, these are all different things that can happen in the body that can affect how the device or the material will perform. So if a device does fail, if we're doing preclinical tests, if a patient dies and they're doing an autopsy, people's implants may be retrieved and then evaluated. So we do it because we may want to study the biomaterials, but then also to evaluate either what has gone wrong with the patient if the device has failed and led to it, or how the device has performed after a certain amount of time. So if we start off with an implant, there's a surgeon and the patient, and it gets implanted. Then you have the patient-prosthesis interactions. There could be complications, different mechanisms go on, you could have local systemic issues. So these are all things that can occur within the patient-prosthesis interactions. If it gets explanted, whether an analysis will occur, and there may be an autopsy, depending if the patient dies or it's just been explanted. When you do analysis, it'll take you around to here. So this is where we may do stuff in the lab to find out what's going on. It may give you information about picking the patient that it goes into. What sort of information can you get from that? Have you designed the right clinical studies? How could you change the clinical studies? There's a whole lot of information that you can get about a material that or a device that has been implanted once it's been explanted, that feeds back to the next round. So whether or not that's a device that is going through development, or you've had a device on the market for a certain amount of time and found out there's this many issues with it, the next iteration of that device could have come from this process. So for implant retrieval, there is a standard for it. Why do we want to have a standard for implant retrieval? So in a similar way to when we make devices or make materials, we have standards so that everything is standardized, so that everything is done the same, and that we know what has been done in a correct way if it's been done to the standard. So the same way as if you want to evaluate something that's been explanted, just like we evaluate in preclinical trials, we have standards for that. We're able to then evaluate a device that has been explanted so that the same amount of tests are going on and that you're able to compare one to another. So it's a way of standardizing things. So there's 3 stages that they've put in the standards to approach implant analysis. So stage 1, 2, and 3. So 1 is the routine device identification, really what it is, what has happened. Stage 2 is more detailed and time consuming, and you're doing analysis to it that is not going to disrupt, or it's non-destructive. And then type 3 are types of analysis that you would do that are going to disrupt the device, the tissue surrounding it. There are some types of analysis that's inevitable. So I've got two groups here and I've listed them. So stage 1 and stage 2 are usually grouped together as group 1, so it's one type of things. So these would be classed as your group 1, which is your stage 1 and 2. So your non-destructive things. So taking photos, doing microbiological cultures, light microscopy techniques as well. So that's all they shouldn't damage the device, they shouldn't damage the tissue, but you're still going to get some answers out of it. And here is group 2, which is similar to your stage 3. These are all techniques that are going to be destructive. You need to take a piece of your sample of the device, of the tissue, to analyse it. A lot of the tests here, particularly in group 2, do they look quite similar to the tests that you may put your device or your material through when you're doing your preclinical testing? So you might do SEM analysis to look at morphology. If you're doing, depending on what the application is, if it goes through blood, if it gets implanted, you might do SEM analysis. TEM is just another microscopy technique. The X-ray microanalysis, that, if I'm right, it should be a type of chemical analysis, so you're able to determine the chemical composition as well. So has your implant been put in there, has it changed the chemistry? You're looking at adsorbed or absorbed proteins onto the surface, mechanical properties and material properties as well. So sometimes it is just as important to work out what has gone wrong with a device and the information that that gives you for the next iteration of the device. The only way that you can find out is by doing the tests once it has been explanted. So I've put two tables, and the two tables come from the textbook, mainly because this table really does summarise in one place what we have learned. So here is two tables about what we have learned from different medical implants that have then gone on to give us more information or help direct the future iteration of that device. So this table is all about heart valve substitutes. So the cage bore heart valves look like this. Have you seen a heart valve that looks like that anymore? So they were some of the first iterations of a heart valve. So what did they learn when they explanted those, or when they were going through medical trials or being implanted into patients? What information did they learn from those that they then took on and helped inform the next iteration? So the cage bore ones, you've got fragments of your heart valves coming off and going into patients, so that's something that you not want. So it sits in where the valve, they've taken out the defective valve, it sits in there, and the ball just goes up and down, and then that's meant to simulate the valve going in and out with the blood flow. You probably get a lot of leaky blood through that as well. But going back and forth, you've then got a ball that's hitting a bit of metal back and forth more times. I forget what type of metal that's made out of. Did a piece of that metal break off and then go? Having that dislodged, having a bit of metal dislodged and going into a patient's heart is not what you want. So that's something that they learnt from it. They then had these cloth-covered caged balls, caged ball valves. So they look the same as the ball and cage, but then they had a bit of woven cloth. Could they have had a bit of woven cloth there? Because it helps to, that's where, this bit here is where the valve, or Where the valve is being replaced, so the tissue that's surrounding the valve is then sewn in to the valve. So they could have put it there to help the integration of the heart valve, but the cloth can cause hemolysis, cause emboli, so you're not wanting to see that occur. So this is just a list of really a very, very nice summary of different types of heart valves, how they've changed throughout time, and some of the things that we've learnt that have gone wrong with those ones, which have helped inform the next round. And then this is from the hard tissue implants. What have we learnt from those implants to what we do now? So one of the first ones was, do not mix metal alloys in the same device. Why do we not mix metal alloys? I probably think you get a few wear particles and that sort of thing. If you've got two different ones, depending on what it is, or depending on what the device is, they could rub against each other. The match of hardness, the stiffness, so that's another thing where you can get wear particles as well. So here are just two lists. I guess I don't want you to learn what it is, but at least have a look at what has gone wrong. At least with the one before, it was going down kind of the list of this is the first heart valve down to, I think they had the biological ones as well. So you can see what has informed them with what has gone wrong in the first ones, leading down to the next ones. So that is all that I have got for today in terms of knowing about sterilisation when devices fail, and then the explant of them as well, and evaluation. If there aren't any questions, tomorrow we will go through a bit about ethics of biomaterials.